Thank you everyone for joining us today. This is the second in our 2018-2019 series of nursing rounds where we've done an afternoon or a noon hour session rather than an early morning session. And with complimentary pizza. So we're really pleased to see a great turnout, and we're really excited to hear Dr. Elizabeth Saewyc talk today about new methods with old data and how to get that RCT rigor without doing a full RCT. So without further ado, I'm going to turn it over to her, and then we're also recording this session too. So if you miss any details, you can always check the recording afterwards. Thank you.
Thanks, Marilee, and thank you to the Committee on the Scholarship of Teaching and Research for shifting nursing rounds to lunchtime. As someone who works with adolescents, I'm not a morning person, and so the idea of an 8 a.m. presentation versus a noon presentation with rolls versus pizza, yeah, it was a no-brainer for me. So I'm really pleased to be able to share this information with everyone. This is literally one of those opportunities where this information is so hot off the presses, it's still smoking. And so what I'm going to be sharing with all of you is information that's just recently been published and is going to be presented next week in Washington, D.C. at the Society for Adolescent Health and Medicine as well. But this is really some of the work that our Stigma and Resilience Among Vulnerable Youth Center research team has been doing in collaboration with colleagues in the School of Social Work and in educational psychology for the last, well, we started this journey about 5 years ago to actually come up with a solution to some issues that I'll talk about, but we're now at the place where we have some new methods. So, to put this in context, as a public health nurse by background, one of the really fundamental things that I recognize and do my work around is the knowledge that health and the greatest sort of influences on health are actually affected most by our environments and our relationships, not our health care and actually seeing health providers, but where we live and work and play and learn in terms of education. And so those broader contexts and environments and the relationships we have in those environments actually influence our health and well-being in some pretty fundamental ways. And so as public health nurses, we try to attend to that. And likewise, the research we do includes intervening at population levels with policies and with programs and with interventions for groups, and evaluating the kinds of contributions, these policies and programs, that other sectors, whether that's the education sector, the justice sector, the social services, or even thinking about sort of the infrastructure, engineering, healthy water, clean water is a key fundamental element of health. So population health interventions are a key part of what public health nursing research evaluates. And for the kinds of research that I do, a key example of that is gay-straight alliances or gender and sexuality alliances in schools. Now, GSAs have been around for about 21 years. They started in the late 1990s in a very few places in the United States and in Canada as essentially youth groups, clubs in schools or in communities of lesbian, gay, bisexual, transgender kids and heterosexual cisgender allies coming together to create support for each other, to actually engage in social justice work within the schools. So different GSAs may be just, hey, this is a group that gets together at lunch to watch movies, or they get together to talk about challenges and problems and to provide emotional support for each other, or they get together to launch campaigns around anti-racism and anti-homophobia and create inclusive schools across a variety of different social statuses. GSAs over the years have had all these different kinds of sort of purposes, and they have often formed like organically within schools with a couple of dedicated high school students who say, we want this to happen, and then they develop, they get a sponsor teacher, or often in a number of places, the public health nurse or school nurse who's the sponsor, or the school counselor, and then they create this group that meets regularly during school year. This has been a potentially beneficial way of supporting LGBTQ two-spirit youth in schools. It can include health education as well as that creating safer spaces. And one of the things that we've seen over the years is that GSAs in schools actually change the climate of the entire school, not just the experience of the kids who are participating in the club. So that has been sort of theorized as one of the mechanisms for creating safer school environments and more inclusive schools, is the way that GSAs, the very presence of them and some of the social justice work they do in the school, contributing to changing the culture of the whole school, not just for the kids who are participating. Now, previous research that we've done in Saewyc has actually, as well as research that's been done by other researchers across the United States and a bit other parts of Canada, has identified that GSAs are linked to lower rates of discrimination, bullying. There's actually been some particular benefits around health that is linked to lower levels of problem substance use and binge drinking, and suicidal thoughts and self-harm and suicide attempts among youth. And in fact, some of the research that we did a few years ago that was published in 2013 and 14 identified that not only were these, the schools that had GSAs linked with lower odds of things like problem substance use and suicidality for LGB youth, but also for heterosexual youth in those schools, which was a little mind-blowing in a variety of circles, because they were thinking, well, yeah, these are maybe great for that tiny proportion of the population who are lesbian, gay, bisexual, and transgender in schools, but what about the overwhelming majority of kids who are straight? Why do we need this? Is this actually going to potentially cause harm for them? And our data suggested that, in fact, no, there might even be clear benefits. However, as we've had drilled into us over and over again, correlation does not equal causation. Just because you see the relationship doesn't mean that the GSA or having that GSA in school actually caused those better health outcomes or feeling safer in school, et cetera, et cetera. The kinds of research that we've been able to do up to this point have been strictly correlational, often with a single cross-sectional school-based survey where you say, okay, the schools that have this is how it looks different. The schools that don't have it, not so good. But the challenge with that is it's very difficult to be able to make causal claims that this kind of an intervention makes a difference. Now, I'm the first to tell you that the news media doesn't always get that. And they're the first to say, oh, look, this is a benefit. But those people who are opposed to supporting LGBTQ two-spirit youth in schools, they get that. And they're the first to actually claim, nah, that research method, not good enough. This is just a relationship. It's not causal. There are some key criteria that are needed for causal inference to be able to be made. And so the key point to why we do this kind of research, or the way you try to design this, is you want to rule out competing explanations. You want to say that this medication is actually what leads to that reduction in blood pressure, or this particular surgical technique is what leads to this kind of improvement, or this therapy or this program or this policy actually led to these outcomes. And in order to do that, you have to rule out the possibility that something else actually caused that, and it just happens to be sheer coincidence. For those of you who have ever had the chance the spurious correlation, if you type that into Google, and you will come up with a website where somebody has actually gone to the trouble of pointing out that you can get some amazing correlations for completely random things. And my favorite was the correlation between the amount of cheese produced in Wisconsin and the divorce rates in, I believe it was Massachusetts or Vermont. And the correlation is like at 96%. Does the amount of cheese produced in Wisconsin cause the divorces? Yeah, maybe not. But so it is important to think about that, actually ruling out the other competing explanations. So some of the things you have to control in doing causal inference is you have to actually deal with temporality. You have to make sure that your cause or your intervention happens before the outcome that you're measuring. Because if it didn't happen before, it can't have caused it, at least not the way we understand time. It's also usually important to be able to measure over time, preferably repeatedly, so that you get kind of that before and after an intervention has happened to see that the change has actually occurred, that there's something that's shifted. One of the issues you have to pay attention to is the cohort effects. If people self-select into particular interventions or participate, then you can't be sure that they wouldn't have already been that way. We think of this when it comes to GSAs as the cool school effect. Maybe it's not really that the Gay-Straight Alliance is actually creating a safer environment. Maybe it's the cool schools that already believe in social justice and work to create safety for students and teachers that are saying, oh, let's do a GSA too. So it is important to actually control for or be aware of that potential. It's also important to recognize that sometimes the cohort, there's something about being in a school or in a hospital, the culture of that community influences that particular group. So if you don't have a comparison group that isn't in that community or didn't get the intervention and is equivalent, then you're not comparing apples and apples, and you're not ruling out those other competing explanations for why something might have happened. Likewise, for causal inference, you need to control for what's called secular trends. Maybe stuff is going on in the wider universe that is changing, that actually has an influence on the broader society, and that's really what's operating, not your particular intervention. So paying attention to if laws are changing and all of, or societal attitudes are changing, or suddenly everyone is deciding that being fit is important, and so it's not your blood pressure medication, it's the fact that everybody's now walking everywhere that is actually changing the health issues. That becomes an important thing to pay attention to. So the goal, wait a minute, it's not going backward. The gold standard for being able to do this has been the randomized clinical control trial. Now, randomized control trials are designed to help rule out those competing explanations using probability theory. That's the assumption that if we randomly select people to randomly be assigned to get the intervention or not get the intervention, if we have enough people randomly assigned, we will be able to, the distribution of what might be different about them occurs randomly in each group. And so we're able to rule out that things just happened by chance. Now, you have to have enough people randomly assigned, and there are some challenges with that, but that idea is that by using probability theory and random chance and random assignment, you can help eliminate the bias of the nurse who says, I don't think this person is going to be a really good fit in this intervention, so we'll just move them to the control group, in the way that they're doing, assigning people consciously or unconsciously to participate in interventions, as well as people who show up for a particular intervention or a particular type of participation may do so because that's what will work for them, and it isn't necessarily being able to measure, does this work for everyone? There are some problems with that gold standard of the RCT when you're thinking about population health interventions rather than for individual interventions with people. Part of that is because population health interventions are for groups, for cities, for schools, for communities as a whole. And the challenge with that is that if you think about an intervention site, it's like, well, if it's a city, if you're randomly assigning people within a city to get the intervention and not get the intervention, and they're in the same neighborhood and they talk to each other, you get what's called contamination effects. We had this happen actually with an RCT we did here on campus around problem drinking, where we actually had to ask young people if they had interacted with people who were in the intervention group or the control group, and it turned out that there were some students who actually lived in the same dorms. And it's like, well, you know, then they talk to each other, and then they start coaching each other, and pretty soon they're really both getting the same intervention, and they're not really a comparison group. So there's that important. The other issue is when you think about a policy change or a large-scale group intervention, can you go to a city and ask them to randomly be assigned to do a policy compared to 1,250 other cities? Not so easy. Even schools, it's like, what? You want us to flip a coin to decide whether or not we're going to do an anti-bullying program versus not, or we're going to change the nutrition content in our, like, it's difficult to get sites, large organizations, to actually be willing to be randomly assigned to take up a policy or a program or not. The other issue is that at a population health level, many of the impacts we're looking for are subtle and they are small, but at a population level, that translates into a huge change. And they take time. You know, it's not as simple as we give you this medication, boom, it changes your blood pressure. Oftentimes, it has to permeate from whatever the intervention is to a wider community, and then that changes hearts and minds and behaviors, and then that creates the outcomes. So it may take time to disseminate, and it may take time for the effects to be measurable and seen. And oftentimes, that effect can take years before it's known. And we don't usually have grants that'll go for 25 years or even 10 years when it comes to research. And oftentimes we need to intervene sooner than just that. And of course, randomly assigning sites is also an issue. You may have 5,000 people in each one of those sites, but the actual power analysis is based on the site. So if you've only got 5 sites, you've got n-1 power, which is not very much for statistical measurement, which means you need lots of sites, and that's expensive. There are very few randomized trials that I've been able to identify that have been funded where you're talking 100 sites or 100 schools to be able to really determine at a population level what's changing. So our question is, if we can't do RCTs because they're too expensive and take too long and so forth, what can we do instead? And this has been part of what we've been looking at over the last 5 years. There are some alternative approaches. You could do longitudinal research within a single school and follow them kind of before and after, and something's been implemented. We do that in clinical settings as well. The challenge with schools is that kids graduate. And in fact, in a high school, they've got maybe 4 years there before it's a totally different population in the school. And so if you've got the kids coming in and the kids leaving and you count to them, you usually only get 2 or 3 years of data from individual kids to follow them over time. And you're kind of limited to how many schools you can actually sample or survey or, you know, be part of it before it becomes prohibitively expensive. If you've got 1,300 kids in a school and you try to survey all of them every year for 5 years, and you do that for 5 schools, you're talking dollars that start going up into the millions, and that becomes a problem. There's also, when it comes to youth at least, a maturational effect. If you're following kids over time, they grow, they change, they develop different coping skills and different statuses. And so it's hard to actually rule out that change happened because of the intervention, as opposed to change happened because they grew older and now they're more senior in school. So that becomes a really important element of thinking about how do you measure or rule out competing explanations. There's also, of course, the challenge with a longitudinal design that you might not have a comparison group, because I can tell you how difficult it is to actually ask a school to participate as a control group or a comparison group where they're not getting anything but surveyed every year for 5 years. Not really interested in participating in that kind of involvement. So another approach is this difference in difference regressions. Benefit of that is you can actually get sort of pre-post with and without the intervention. You can actually do multiple cross-sectional data collection. You don't have to stick with the same kids each time, but you can't test for non-linear. It's linear regressions, and you can't test for non-linear. It gets better and then it plateaus, or it gets better and then it starts getting worse again. It also doesn't allow you to test additive effects. The longer you've had it, the more people are involved, the better it gets. It also assumes that the cohorts you're sampling are identical or homoscedasticity. That is, if you're then sampling totally different kids each time around, and there's something different about this group, something different about this cohort because of time, because of what's happened, then you've got a problem. Likewise, this method assumes that the residuals from your regression are all independent, but if they're clustered, if people are clustered in schools, then the environment, they're not independent, they're part of a context. And so that means that you actually have problems using this kind of a method when you've got clustered data in sites like hospitals or schools. Another approach is interrupted time series, which actually helps address some of those issues, because you can vary when the intervention happened and that sort of thing, but it still has some of those same assumptions around homoscedasticity of participants, the independence of residuals, and worse for schools, you need a minimum of at least 8 measures before the intervention and 8 measures after the intervention. And if you're doing school-based surveys that are every 5 years or every 3 years, you're going to have like 5 generations. But like by the time you actually finish your study, it's going to be 50 years, and it's going to be irrelevant because, you know, so many things will have changed about the context. So we went back to the drawing board and said, right, so what do we do if we can't do that and this isn't ideal? What are some options? Are there ways that we can use existing data in new ways to get at this? So we started with what we had, which is the BC Adolescent Health Survey, which is a cluster stratified random survey in which classrooms in grades across grades 7 through 12 throughout the province in participating school districts, which is nearly all of them, are randomly selected to be surveyed in every 5-year periods. In fact, we've just finished the 2018 last February to June, and we will be launching the results from that, the first sort of highlights report coming out in March. You may see some news about that. This is actually a survey that's administered by public health nurses and nursing students across the province. Now, this is cross-sectional data. So each time, if you've got 5 years between them, you've literally graduated the entire, like the grade 8s are now graduated by the time the next survey comes around. The GSAs, we actually did phone calls to all the schools to identify what year the GSAs started. And we've got them starting at all different times. There were like 2 GSAs that actually started 14 years before in the late 90s. And there were other GSAs that, like other places that have never had a GSA. And so when you think about that and think about, well, so this design, it's like We don't even have necessarily the same schools or the same grades in each survey round. So this is like the totally wrong design for trying to do an intervention study. You know, if we could have designed a data set guaranteed to be the worst possible for intervention analysis, we couldn't have done better than this. But we've got some really, really brilliant people in educational psychology who worked with us, and Amory Wu specifically is one of the stars over there, who we brought this information to her and said, so what do you think? And aside from a kind of disgusted look on her face the first time, she said, interesting. Yes, I think we could do something, but this is an interesting problem because basically we're breaking all the rules that we tell people are needed to do the right kind of intervention research. So one of the things we did in thinking about this is, what if instead of thinking about the individual person as the unit of analysis, we think about the school with or without its GSA and wherever that GSA started as the unit of analysis, and the kids in that school and their responses as the school level kind of response. It took us a while, a lot of, and I think it's like 4 or 5 postdocs along the way that participated, and some fabulous doctoral students who are working with us. But we have come up with a method that we're calling SLEPHI, site-level longitudinal effects of population health interventions. This is a method that uses multi-level, multi-group modeling, so basically multiple groups nested in schools, to look at school-level outcomes, controlling for where they started and comparisons at their, within schools across a particular time point, as well as, or within schools over time, plus across schools at each time point that we might do the survey. And this gives us an opportunity to control for things like cohort effects and things like maturation effects and the variety of processes. It allows us to actually figure out doing this rather than saying, do you have a GSA or not? It's how long have you had a GSA? Ranging from 0, we've never had one, to, 2 to 4 to 12 years. It's a repeated measures type of analysis. And for those who have specific interest in this, one of the benefits is it does control for secular trends, because you have a comparison group that has never had the intervention, and they're followed over time, the same as others. It has cohort effects it can control for, because you've got different samples in each survey, but you can control for that variation as part of the analysis. It deals with that issue of maturation, because you're not following the same kids over time as they grow and change. You're following the same age kids, different kids, but at their same age. So you get different 7th graders and different 8th graders and different 9th graders each time you do the survey. So you're still capturing that same developmental age, just before and after the intervention. Structural equation modeling in this particular multi-group, multi-level approach also allows you to adjust for measurement error, because there's always a certain amount of measurement error, and more importantly, measurement equivalence if, as happened in our survey and happens frequently in school-based surveys, your measure changes slightly over time. So we changed the number of response options from 3 to 5 in 1 year. And the other years it was just 3 response options. You're like, oh. Normally you would say, don't do that. This actually allows us to help control for and ensure that there is equivalence of that measure across time. So for this presentation, I am not going to go into the in-depth geeky experience of this measure. There will be no equations. I am not going to use a lot of the jargon, but for those who are really interested in more detail about this approach, Social Science and Medicine Population Health just published this. It's open access. And in addition to providing all of the equations that describe the specific model, there's an electronic supplementary file that includes the syntax and the output for the analyses that we did as an example, so that people can actually see what it looks like when you do this kind of research. We essentially used it to answer the question, what's the effect of the length of time since a GSA has been in place and the perceived safety at school among the lesbian, gay, and bisexual teens and among the heterosexual teens? So to give you a sense of what we had to work with, we actually had 135 schools that had participated in all 3 years of the survey, 2003, 2008, 2013, and had the same grades involved so that they were pretty equivalent. And that translated to almost 500 and then over 600 LGB students in those schools, and between 10,000 and 15,000 heterosexual students in those schools across the province in those years. We actually saw an increasing number of schools get GSAs over the course of that time. So in 2003, there were very few schools. 93% didn't have a GSA. 7% had a GSA. And they'd only had a GSA for between 1 and 4 years. But by 2008, that number had dropped to only 2/3 of them hadn't had a GSA. And the amount of time, of course, was between 1 year and 9 years old. And by 2013, more than half of schools had a GSA between 1 and 14 years long. Our school safety measure actually has 6 questions that ask, how safe do you feel in different parts of the school? From the library to the cafeteria to the bathrooms to hallways out on school property. And the options were never, rarely, sometimes, often, always. But as I said, in a couple of the years it was never, rarely, sometimes, always, often. And then in a couple of years it was all 5 of those as a separate category. And after doing sort of the measurement, we looked at and recognized that we could dichotomize that to the never, rarely group, and then the sometimes, always, often group as the 2, and then add them up as a overall safety in school kind of measure. Now, across all surveys, the LGB youth felt less safe in school than the heterosexual kids. So the percentage who said they never, rarely felt safe, libraries were still some of the safest places for most people, but only 2% never or rarely felt safe among libraries among the heterosexual kids, whereas 7%, or 3 times as many, didn't feel safe among the LGB youth. And the different places in schools varied in terms of the percentage of students who never felt safe. When we did this analysis, this approach actually tests a bunch of different models, 4 different models specifically for their fit. The first one, we control for age, because LGB kids on average are a little bit older than heterosexual kids. And then in order to test the fit of the model, we constrained the slope of how long the relationship between GSA length and the outcome of safety, and said, let's make it equal across, let's pretend like it's equal across every one of those years to see if that fits. Then the next model, we said, okay, let's not pretend that they're equal. We don't require them to be equal. Let's just let them vary. That didn't fit as well. Then for the third model, we said, well, maybe it's not linear effects. Maybe it's actually some sort of up and down sort of effect, a quadratic effect. So let's try that and see if that fits. Nope, that did not fit. A linear model fit better. So that we were able to sort of assume that this was a linear relationship. And then for the last model, we said, well, let's take out the covariate of age. Maybe it's not necessary. Let's see if that makes a difference. That also didn't create a good fit. So ultimately, we selected model 1 as the best fitting model. And what it suggests is, in fact, that there is a linear relationship. The longer you've had a GSA, the safer kids feel in school, and that relationship is equivalent every time you do the survey, whether that was in 2003 or in 2008 or in 2013. Specifically, for those who like effect sizes, what we found was that there was a 0.32 standard deviation per year increase in perceived safety among LGB students. Importantly, there was no plateau. This wasn't it's all good until about 5 years, and then after that it starts getting worse. It's like the longer you've had a GSA, the longer the effects continued. And we saw the slope was the same across each year of survey measurement. Now, for the heterosexual kids, similar but not quite. They actually had a slightly larger, not really enough to be excited about, but a 0.34 standard deviation increase in safety for each year of a GSA in 2003 and 10 years later in 2013. A slightly tinier number in 2008. Those slight differences, our team is speculating maybe due to the massive, massive size of the heterosexual group. Keep in mind, it was like between 10,000 and 15,000 students in each group. But what this means is the longer a GSA is in school, the safer all students feel. Not just the LGB students, but the heterosexual students as well. And that these are long-term environmental effects. Long after a particular cohort of kids have graduated from school, this is clearly having an effect on the climate of the school, such that 14 years later, we're still able to see effects and the continuing effects of the intervention being in place. Now, why this matters is because at the moment, we are in a place of social upheaval and controversy and a lot of pushback in society about how we create safe spaces for students in schools. And when kids aren't safe in school, they can't learn very well. But we've seen specific pushback here in BC and in Alberta over the last few years, and it's gotten even stronger just recently, in terms of schools, like groups in the community saying gay straight alliances, sexual orientation and gender identities education to create safer spaces is against our religious beliefs, or it's against, we think this is a massive social experiment, we think it teaches kids sex ed too soon, like all kinds of claims. And a key one they've made is that it's harmful for young people who aren't lesbian, gay, or bisexual, or transgender, that kids who are not already identified that way, but kids who might be questioning, or kids who are straight, this might cause harm to them. Our research provides evidence that controls for the kinds of things that you need to be able to control for in order to establish causal inference, the way an RCT does. Well, not the way it does, but in similar ability to create some of those claims. And as a result, we can say, actually, no, it doesn't cause harm. It actually makes all kids feel safe in school. And where this becomes particularly relevant for us is that at the moment there's a charter challenge going on in Alberta where they have a specific GSA law, and different private school groups and other interested parties are trying to challenge that law, saying that it is violating parental rights, religious freedoms, and that it's harmful to kids. And our team has been asked to provide research evidence to the court on what is the known sort of the strength of the evidence and the recent information in order to be able to, for the court to weigh those claims against what the law is designed to do. So up until this paper was published, if I'm going to go to that court, I'm going to have to say, well, you know, we've got all this lovely evidence, a lot of it from the United States, which people go, yeah, that's the states, they're different. And most of it is correlational, and it suggests an improvement, but it doesn't control for enough things to rule out many of the competing explanations. This approach ratchets up and adds to that existing correlational evidence and adds to some of the small longitudinal studies that have been done in like a single school or two. And altogether, they add up to the same evidence that this is helpful. We are just putting a serious stamp of, yep, we've ratcheted up that rigor a little bit further. Now, for us, the exciting thing is, of course, GSAs and anti-homophobia policies and school-level interventions. That's where the work I do around school nurses and public health nursing is the exciting piece. But this method can actually be used for other types of sites. You could do research where you're regularly gathering annually or every few years data in hospitals. And that's a cluster. So those cluster stratified random controlled trials, which are fiendishly expensive, you could instead do this kind of approach with regularly gathered data from hospitals or from clinics or from communities or even from countries or regions. We're part of the Health Behavior of School-Aged Children, Team Canada, along with 47 other, 50-some now, countries in Europe and parts of Central Asia. And those are regularly recurring surveys of adolescents every 4 years. Potentially, we could look at country-level differences in policies or laws and use this kind of an approach to actually do evaluation, because those are cross-sectional data points that are regularly gathered, and this is another efficient way to actually reuse the data. Now, there are some requirements for the design. You have to have at least 10, or you can't have more than 10 cycles of data. So for me, that's like, oh, well, yeah, we don't want 50 years. 50 years of data, things have changed too much. So 3 to 4 is good. But for others, if you're doing this every year, 10 years of data is about all you can get for this particular methodology. Preferably, you need 50 or more sites that you're followed, even though it's different people in each site or each cycle of the site, but you need to follow at least 50 sites. But that's what population health research is about. The start dates of the interventions can roll out at different times. They're not controlled by the researchers. That's a bit of a natural experiment. And the intervention length, how long the intervention is in place, can also vary, which is why that becomes particularly efficient and cost-effective. You don't have to control as many things to be able to get to that randomized clinical trial. This is a green method, reusing and recycling. It does allow us to actually evaluate those non-randomized population health interventions and the natural experiments that happen when groups take up an intervention like, we're going to change the soda pop in schools to water only, and other groups go, no, we're not doing that, or okay, we'll come along and do that 5 years later. You can actually, that's okay. That doesn't mean that you've screwed up your intervention and people aren't happening at the same time. But it also meets the criteria for improved causal inference, which is one of those key pieces. And you've heard it here first, this is actually, as of next week, an award-winning method. We've just been informed that our paper presenting this method at the Society for Adolescent Health and Medicine next week on Wednesday has been selected to be awarded the Robert H. Durant Award for Statistical Rigor and Innovation in Adolescent Health Research. Which, as someone who knew Rob Durant before he passed away, he was quite the stickler for rigorous statistical methods and the latest cutting-edge techniques. And there is only one of these awarded at SAM, which is an international adolescent health professional organization. There's only one awarded each year. So for those of us, it's like, yeah, we got the geek Oscars. Thank you. Questions?